this case was a little challenging. All right. Obviously, I went through the planning. I took my pictures, but you can see on the X-ray, we can expect a maxillary cant, meaning we'll have to remove more bone on that right-hand side. There's large pneumatized sinuses into the second premolar space, affecting my AP spread. There's flaring of the anterior alveolus, which means I'll have to have a great angle correction in my implants. This is kind of how the planning went. It was based on her functional and aesthetic needs, and we took into account her functional limitations. She happened to be a tiny lady, didn't open very wide. The extra reduction required to align and straighten the bone, the creepy sinuses meant my distal implants would be limited in my AP spread. This is my design. My design with the lab. I opted to take the second premolar out because I really don't like having cantilevers if I can avoid it. One of the most important things to do when you start this procedure is your flap. You really can't be scared. I like to try and save all the keratinized tissue if I can. I like to make a crestal flap around them. I like to have solid buccal releases so I can really have a great reflection. So I can see everything also fit on my guide. Also gives me great room for my alveectomy. And again, there's not much anatomy that you can really harm here. No, especially when you're back in the molar region. There's no arteries or nerves popping out. Really safe. Also makes your surgery just so much easier. The guide is fixated into place with bone screws. I prefer bone screws versus pins. They're just more stable, and you put a lot of pressure on these guys and vibration. I just find that they work better in my hands. After the MUAs are all placed, I then normally start grafting around those implants. Grafts really should be placed around implants with gaps of 1 millimeter or more. If you see a thin buccal plate, you really should kind of graft around that as well for the long term. Or the longevity of the implant. There's many ways to kind of do this. You can just do interosseous sutures where you put holes in the bone, you kind of suture the tissue to the bone. There's a famous Texas two-step closure where you do a running vertical followed by a running baseball stitch, either or, but the key is you really want to kind of push this tissue down in order to make that multi-unit visible. Here's the quick converts abutments. Again, also a quick procedure. Here's my local lab that I used to hire to come on in. Again, great savings because these guys are not cheap to come on in. Here's her temporary denture delivered the same day. Okay. And actually, here's her 4 months later. You can just see how well the tissues healed, the response of the implants to the tissue. She's going to have a great outcome.